Hi, I'm Stephanie Mason-Teague, and welcome to A Healthy 100, where we help you become proactive in living a healthy, active, and productive 100 years. Today on the program, we have the Chief of Staff from Florida Hospital Fish Memorial to talk about advancements in cancer treatments. We'll take a look at brachytherapy, and then we'll be joined by a special canine guest. We're pleased to have Dr. Jeremy Steinbaum here with us today. Dr. Steinbaum is certified by the American Board of Surgery and is consistently listed in Orlando Magazine's Top Doctors. Dr. Steinbaum is the medical director at Blue Springs Surgery Center and also the founder of the North Orlando Surgery Group. Welcome to the show, Doctor.
Thank you, Stephanie.
Thanks so much for being here.
It's my pleasure.
I think most people nowadays know of the importance of early cancer screening, but maybe aren't as familiar with the new technologies and advancements in cancer treatments. What can you tell us about brachytherapy?
We have a new exciting technique available as a replacement for standard radiation therapy for breast cancer. In this case, brachytherapy is given through an intracavitary device to treat the space where the lumpectomy was performed.
And there's another acronym, HDR brachytherapy. What is that specifically?
HDR is short for high-dose radiation, and it speaks to the rate at which the radiation is delivered or released by the seed that's put into the cavity.
And you've brought some things with you here. Can you show me a little bit about, it's kind of technical, it sounds anyway. How is that device used?
It's not actually as complex as it sounds. Essentially, when we do a lumpectomy, we leave a balloon catheter behind in the cavity where the tumor was removed. It's a very flexible catheter. It allows for maintaining of the space and adherence of the tissue from around the cavity against the tip of the balloon. This is a temporary device. We don't treat through this cavity device. However, after we've confirmed that the patient's an appropriate candidate, we can replace it with a treatment balloon. This is one variety of a treatment balloon. It slides into the space where this catheter is removed from, and then through this device, we can deliver the radiation.
So that device is actually inserted into directly where the cancer is located then?
Where the cancer has been removed, we have a cavity, and in that cavity sits this balloon. In the center of the catheter where the balloon sits, there's the ability to deliver radiation into the center of that balloon.
Okay, so you're actually hooked up then. This is fascinating to me. I want to make sure that we understand it. So this end here is hooked up to the radiation.
Yeah, this is the latest treatment balloon. It's a multi-lumen device where you can actually calibrate exactly how much radiation to various areas around the balloon. The original devices had a single lumen, a single channel, and the radiation seed was placed into the center of that channel. And then you had an expected amount of radiation given around the balloon. With this multi-lumen device, you can actually put a smaller amount of radiation closer to the skin or closer to the chest wall, and a higher dose closer to the surrounding tissue.
It sounds very specific, and that alone seems like it would be a benefit. Are there other benefits to the HDR brachytherapy?
There are quite a few, actually. The standard approach to radiation therapy is typically a dose a day, 5 days a week, Monday through Friday, for up to 7 weeks. With brachytherapy delivered into the cavity, we treat twice a day for 5 days, and you've, in 10 treatments, have received the entire dose of radiation that you need.
Wow.
The other advantages are less fatigue. The other advantages besides shorter duration, less fatigue, less irritation to the overlying skin, less injury to the chest wall and lung, less firmness of the skin, less discomfort in the skin, and less disfigurement of the breast.
That all sounds like some great benefits. Are there any side effects?
In my experience, the side effects are minimal. You can still experience some fatigue related to just having gotten the radiation dose, but certainly not as much of the fatigue that we typically hear complained about with standard radiation therapy. There can be some overlying irritation to the skin depending on how close the cavity it is to the skin. We really don't see much side effect of treatment closer to the chest wall. We just worry more about potential injury to the chest wall and lung. Because there's a catheter in there, you have to put up with a catheter for a week. So there's a little bit of discomfort associated with that, or really not discomfort so much as it's annoying. It's hanging out of you. But after a week, after you've received your 10 doses, the catheter comes out and the hole closes right up.
So is there any danger of infection? So I didn't realize then the catheter stays in during the 10 days.
Right.
So is there any risk of infection?
There is a small risk of infection associated with it. Some physicians are using antibiotics. I haven't used antibiotics, and I have not had a catheter infection as of yet. And it's actually in there. We put this temporary one in for the first week, and then the treatment balloon for the second week. The temporary cavity evaluation device, it's actually at the surgeon's discretion as to whether or not they want to use one or not use one. You can always put a treatment balloon in without having had one of these temporary catheters in place.
All of that kind of sounds too good to be true. It sounds like it's faster, it's more effective, there are no side effects. So brachytherapy is not the same thing as chemotherapy?
No, and chemotherapy is systemic treatment, and we use chemotherapy having to do more with the size of the tumor and the behavior of the tumor, presence or absence of lymph node involvement, et cetera. Essentially, chemotherapy delivers toxic medication all over the body, wherever cancer cells may be hiding, so that you can actually kill the cancer cells. What we're trying to accomplish with brachytherapy specifically is a way of achieving the same kinds of rates of local recurrence that one would expect from mastectomy or lumpectomy with standard external beam radiation therapy.
And those sound much more invasive than, I mean, you're getting the same results.
Certainly, mastectomy is a bigger operation, and it's very disfiguring. There are a lot of emotional and psychological effects that we see in our mastectomy patients, which we don't see in our breast conservation patients. With standard external beam radiation, which provided a much better cosmetic effect than mastectomy, obviously, there still could be some differences between the two breasts as far as size of the breast, shape of the breast, color of the skin overlying the breast, and the suppleness or lack of suppleness in the skin. With brachytherapy, we've kind of addressed that issue. We've gone one step further, avoiding the hyperpigmentation, avoiding the induration, that's firmness, and avoiding some of the tenderness that comes along with standard radiation therapy.
Well, having heard all of that good news of the benefits and the low occurrence of side effects, are all patients good candidates for the brachytherapy?
We're currently restricted in brachytherapy for breast cancer by very strict FDA guidelines. Those FDA guidelines are based upon the information that we have to date in studies over a longer period of time. And rightly so. We want to make sure that we're achieving the same as the gold standard having been mastectomy, and now more recently lumpectomy with external beam radiation therapy. Those are our standards that we have to hold ourselves to make sure that we're achieving the same kind of local recurrence. So the studies that we have to date are specifically designed in women that are less than 45, older than or equal to 45 years of age. Tumors that are less than 3 centimeters in diameter, and in lymph node negative patients. I expect in the future that those restrictions won't be quite as stringent once we get more data on ongoing studies in women less than 45, in tumors greater than 3 centimeters in diameter, and in node-positive patients.
Now, two of the requirements are obvious, the age and the size of the tumor. But what does negative lymph nodes mean, and how do you test for that?
When we're staging breast cancers, we need to know whether or not the cancer has gone from the breast to the lymph nodes in the armpit, the axilla. Once upon a time, we cleared out as many of the lymph nodes from the armpit as we could. Unfortunately, that left patients with a very high risk of lymphedema and infection in the arm on that side. We learned later that that didn't give any benefit as far as reducing the risk of recurrence or prolonging long-term survival. So really now we've gotten to the point where instead of clearing out the lymph nodes, we really just need to know whether or not there's lymph node involvement in the axilla, in the armpit. A newer technique, which isn't so new anymore, it's at least 10 years old, is called a sentinel lymph node biopsy, where we pick the lymph node from the armpit or lymph nodes from the armpit that act as guards for that lymph node basin. Sentinel is another word for a guard.
Okay.
And we have two ways that we help identify those lymph nodes that guard the axilla. The first soldier in the armpit that'll stop the cancer spread to other lymph nodes in the armpit.
Okay.
We use both a small dose of radiation that specifically goes to the lymph nodes from the breast and a small amount of blue dye that specifically goes from the breast to the lymph nodes to identify those nodes that guard the axilla. Sometimes it's one node, sometimes it's as many as 5 or 6 nodes, but if we pick out those guarding lymph nodes and examine them more carefully than we would normally evaluate lymph nodes, we can find out whether or not the cancer has gotten to the lymph node basin and then make a decision about systemic treatment.
And how many lymph nodes are there in total? To get a better idea, if you're removing from 1 to 4, how many are there?
It's variable, but we know that there's at least 30 to 45 lymph nodes in an armpit.
Wow.
And when we did aggressive mastectomies and took all of the lymph nodes out of the armpit, typically we were seeing a harvesting of 25, 35, or 45 lymph nodes from the armpit.
Wow.
And those were the women that were left with severe swelling on that side. With sentinel node biopsy, taking out 1 to 6 lymph nodes, we don't see nearly the incidence of lymphedema in the extremity.
So another good benefit of the advancements. Well, you say it's 10 years ago, but that's still an advancement that is good for the doctor and for the patient.
Absolutely.
Now, here on A Healthy 100, we like to help strive to reach 100 healthy years. So what kind of advice would you like to give our audience and viewers about the best cancer prevention strategies?
Well, we know specifically for breast cancer and for many cancers that avoidance of cigarette smoking, being a healthy weight, not being obese, and being part of a regular exercise program will reduce the risk of a lot of cancers, including breast cancer. Being aware of your family history so that you know whether or not you're in a high-risk group is helpful. And then specifically for living that healthy 100, early detection is very important in breast cancer. Regular mammography, regular breast examination, close surveillance, especially in high-risk patients, has been demonstrated to increase survivability, increase your chance of living a longer and healthier life.
Wonderful. Well, thank you so much for being here. Now, we went over a lot of technical information and a lot of information. I'm sure that our audience may have some questions. Can we go ahead and take some of them now?
Sure, happy to.
Okay.
Hi, I'm Pat from Barry. And I was wondering if this HDR that you use can be used for other cancers, like lung cancer.
There are multiple applications for brachytherapy and HDR in specific. And there's actually 2 forms of brachytherapy, but before I get to that, lung cancer within the lung parenchyma or the tissue of the lung has not yet been one of the cancers that we're using brachytherapy on. That having been said, when there are small cancers inside the tracheobronchial tree, the airways that feed the lungs, there is application of HDR that can be passed down a catheter to the area of the tumor and provide high-dose radiation locally to the tumor on the lining surface. Still, the gold standard for a lung cancer is surgical removal plus minus radiation and chemotherapy, depending upon the patient's performance status, the size of the tumor, the presence or absence of lymph nodes, whether or not there's been spread elsewhere in the body. Other places where HDR is regularly used, we have applications for the uterus, the cervix, some localized treatments for the esophagus, and more commonly, and most commonly in the prostate, where prostate radiation seeds are deployed. That's actually LDR therapy. It's longer, slower release of radiation, and the seeds are left behind in the prostate until the radiation just stops being released. The counts are down to 0, but the seeds are left behind.
Thank you.
My pleasure.
My name is Maud Kalkowski, and I'm from the Barry. My question was, the procedure that you are talking about, is it applicable to melanoma?
That's a good question. We actually have application of HDR for skin cancers, but not for melanomas. We're having a little bit of trouble with delivering enough radiation using that kind of brachytherapy to actually treat melanoma safely. Basal cell cancers and squamous cell cancers have been treated with HDR, and successfully so. Most skin cancers, including melanomas, are treated best by surgical removal. Melanoma is a different breed. Melanomas are more aggressive, and they tend to spread earlier to lymph nodes. So depending upon the thickness of the melanoma, the depth of invasion of the melanoma, one may actually need a sentinel node biopsy when their melanoma is removed. And if the sentinel node is positive, then actually a lymph node dissection of that area is appropriate. Then we may or may not need radiation, but still the primary treatment for melanoma is surgical removal.
And I was wondering if you know anything about microbiotic diet when you have any type of cancer.
There's actually a lot of data now on antioxidants and macrobiotics and micronutrients and microbiotics. I think essentially what those of us in the medical community have come to adopt as a recommendation is avoidance of obesity is probably the number one. Whatever diet that you go on, as long as you're not overweight, and if you are overweight, you're losing weight, and add exercise to your diet, you have gone a long way to reduce your risk long-term of cancer. There's not a great body of scientific data yet available on the benefits of some of the other diets, how much antioxidants one needs, how much macrobiotics versus micronutrients and microbiotics one needs, et cetera.
Thank you.
My pleasure.
Dr. Steinbaum, thank you so much for joining us today and answering so many of our questions. It's a great benefit to our audience and viewers. It's always such a pleasure.
Thank you. The pleasure is mine.
For more information on Dr. Steinbaum, log on to fhfishmemorial.org.
We're very excited to have two special guests with us today, the president and founder of Caring Canines, Rina Lavelle, and her dog, Chance. Hi, Rina.
Hi.
Thanks so much for being here and bringing this cute dog, Chance.
Well, we'd love to be here.
Now, tell me a little bit about your program. What is Caring Canines?
Caring Canines is a 501c3 nonprofit organization of therapy dogs and their handlers. We've been in existence since September of 2003.
And how did you get started?
I got started